Hi students, you're listening to the recording on Chapter 25, Assessment of Cardiovascular Function. The objectives for this chapter, you should be able to describe the relationship between anatomic structures and physiologic function of the cardiovascular system, explain the proper techniques to perform a comprehensive cardiovascular assessment, discriminate between normal and abnormal assessment findings, discuss the clinical indications, the patient preparation, and other related nursing implications for common tests and procedures used to assess cardiovascular function and diagnose cardiovascular disease. You should also be able to compare various methods of hemodynamic monitoring with regard to indications for use, the potential complications, and the nursing responsibilities. So if you need to review the A&P, it is in the book. We'll do a very quick review of the assessment of cardiovascular function. I just want to point a few things out. As far as risk factors go, make sure that you can identify the modifiable risk factors. So look at dietary modifications, exercise, weight loss. These are important strategies for managing cardiovascular risk factors like hyperlipidemia, hypertension, and diabetes. So if they are obese and they have a high salt, high fat, high cholesterol diet, and they have a sedentary lifestyle, then they're going to be at higher risk for getting cardiovascular disease and diabetes than they would if they had low fat, low salt diet, and they exercised regularly and they maintained their ideal weight or BMI. During the health history, make sure that you determine if the client and any immediate family members can recognize symptoms of acute cardiac problems. So if you have someone who is at risk for cardiovascular disease, are they able to identify the clinical manifestations or signs and symptoms of acute coronary syndrome, heart failure, an MI, or myocardial infarction, heart attack? Can they identify those and seek immediate treatment once those symptoms arise? Especially if you're having symptoms of a heart attack, if you're a female, you'll have atypical symptoms. So they need to be able to understand what the symptoms are, what they need, and when they need to seek treatment in an ER versus just calling the physician, going to an urgent care center, or just like a minute clinic type of a situation. With medications, if someone is at risk for cardiovascular disease or they do have coronary artery disease, they might be put on aspirin. It is a over-the-counter medication, and it can be like a Bayer baby aspirin, 81 milligrams. It also can be 325 milligrams. It just depends on what the doctor wants to do. If it's more preventative, it's going to be 81 milligram dose. It improves outcomes in patients with coronary artery disease due to its antiplatelet action, so it does act as a blood thinner. That is important to note whenever you're providing education. As far as nutrition goes, again, they should have a low fat, low salt, low cholesterol diet, but what kind of diet are they really following? A lot of them, if you ask them about their diet and they tell you what kind of diet they're supposed to be following, you need to ask, okay, but what are you following? 24-hour diet recall. Activity and exercise are important because if they have a sedentary lifestyle, then they don't have much endurance. So when you're asking about activity and exercise, you can find out a lot about their endurance level and what they can tolerate, what they can't tolerate. When asking about elimination, are they having to get up to go to the bathroom throughout the night? It can be because of some sort of just aging bladder issue, but it also could be a symptom of heart failure, especially if they do have edema or leg swelling in addition to that. If they have constipation and are having to strain to have a bowel movement, then you would be concerned about the Valsalva maneuver, which will trigger the increased pressure triggers the baroreceptors, which causes the heart rate to go down. As far as a general physical assessment, you're going to look at their skin. you're going to assess their pulses, and you'll assess the carotid pulses. You'll listen to the apical pulse, and then you can check the pulses of the most distal extremities. And if those are nice and strong, you don't have to go up to the more medial pulses. You can look for jugular vein distension and pulsation. You can feel for the carotid pulses. You can listen for bruit and listen and feel for bruit and thrill as well with the carotid pulses. And then you can look at the chest wall, listen to the heart, and then see, what do you hear? S1, S2, S3, S4? Do you hear murmurs? Do you hear regular, irregular beat? S3 is considered normal for children and adults up to about 35 to 40 years of age. It's referred to as physiologic S3. If you have a patient with an artificial valve, if you're listening to the heart of an older adult, or if you're listening to anyone who takes a beta blocker and you hear an S3, that is abnormal and you'd want to call the doctor right away. So if you do have an adult that's under the age of 35 or 40 and they have artificial valves or they're taking beta blockers and you hear an S3, then you would want to call the doctor. But a normal young adult, you can hear S3 and that's completely normal. As far as lab tests, your cardiac biomarkers, you're going to get troponin, excuse me, CK, and then CK-MB or myoglobin. A troponin is specific to cardiac muscle. It can elevate within hours after an MI. And it is an accurate indicator of myocardial injury or ischemia. The reason that they do the troponin, the CK, and the myoglobin is not specific to cardiac muscle. It is just deals with smooth muscle injury, but it will show up in as early as 1 hour, where troponin will show up within hours, but it's usually 4 to 6 hours. Troponin will also stay elevated for an extended period of time. So your CK will show up about around the same time as your troponin, but it is only there for about 48 hours, and then it will go back to normal. So when you do all three together, you can really isolate and kind of give your best estimate of when the MI took place. You will get a lipid profile, and it's going to tell you your HDLs, your LDLs, and you just need to know your good versus your bad, what they mean. So elevated LDL levels with decreased HDL levels are associated with greater risk for coronary artery disease. Okay, so your HDLs you do want to be higher because those are your good ones. Your LDLs you want to be lower. And there's a full list if you want to look at the table. A BNP, brain natriuretic peptide, is going to be done for patients who have heart failure, and it'll be elevated in heart failure patients. You can get coag studies, especially if they are on anticoagulation medications, looking at the INR and the PTT. You can look at their electrolyte levels just to make sure nothing is abnormal because that can affect the heart function. You can look at their COP, homocysteine, but those aren't as common as the other ones. If you get an ECG or EKG, some people will say EKG instead of ECG. It just shows the electrical activity of the heart, and so this can show you kind of what's going on with the electrical conduction in your heart, and you can isolate exactly where in the heart you're having issues if it's an electrical conduction issue. You can do a 12 lead, and that shows you all different areas of the heart. You can also have them on continuous monitoring via telemetry, and that's usually a 3 lead, but it's continuous. So they're able to get up and move around and do what they need to do, and you can promote them walking in the hallway. It's less cumbersome than doing, having all 12 leads on them. And then there's usually a teletech that will watch and see if there's anything going on with those types of patients, but it gives 24-hour monitoring. You can also have monitoring at home, and they can wear a Holter monitor, and there's other devices that can monitor the electrical conduction of the heart when they're at home. So it's not just something that can be done in the hospital. They can do cardiac stress tests. They do two types. They can do an exercise stress where they put the patient on the treadmill and they watch the electrical conduction of the heart, and they also watch your heart rate and your oxygen saturation and your respiratory rate. And they'll do it with you not moving at all. And then they do it with the patient doing a slow walk, and then they'll slowly increase the speed on the treadmill and the intensity on the treadmill to see if they get any kind of a reaction. If they reach the target heart rate, don't have any adverse effects, they'll stop it. They will stop it if the patient starts to become symptomatic or can't tolerate the stress test. They can also give a thallium stress test, and if they are not able to do an exercise stress test for whatever reason, they can inject thallium. And it kind of mimics the strain on your heart that you would exert if you were exercising, and they can monitor symptoms, vital signs, and the ECG just as they would if the patient was walking. They can also do different types of nuclear med type testing, and they can do myocardial perfusion imaging. And there's two different techniques that they can use. They can use the single photon emission commuted tomography, or SPECT SPECT. They can also do positron emission tomography or a PET scan. It's commonly performed after a patient has an acute myocardial infarction, and what they're trying to see is how much damage it has occurred. So they're looking at arterial perfusion of the heart to see what kind of damage was occurred from the MI. They are used in combination with stress testing, and so you have at rest, and then whenever you apply some sort of stressor to your heart, so whether you're walking or doing the thallium stress test, to see if you see any kind of deficit, reduced perfusion, or no perfusion. If you see ischemia, whenever that happens, especially with someone who's having a lot of chest pain but not showing an active MI, then they might just have some sort of partial occlusion that gets worse whenever they exercise or exert any kind of energy. And then you can also have tests for ventricular function, and it's called the equilibrium radionuclide angiocardiography, or ERNA. And it is also a scan. It's non-invasive, which is nice. And you just get images that are recorded of the heart during multiple heartbeats. And so they'll monitor the heart and record images during heartbeats, and then the computer will process all of the data and analyze left ventricular function, the motion of the wall, and then it'll also look at ejection fraction. And then you can always do the CT scan, and you can do it with or without contrast. And that, as far as nursing is concerned, is no different than a CT scan is a CT scan. So that and an MRI are both, you're going to do the same for nursing interventions as far as providing details of the procedure, make sure that they are aware of what's going on. If they get anxious, then you need to make sure that you let the doctor know about that, see if there's anything that they're able to give. Since they are looking at the heart, I don't know if they'd want to give a sedative or not, so that's up to the doctor. It is painless. The only thing, again, your patient has to lay completely flat, and they have to be still. They can't move at all. Magnetic resonance angiography, or an MRA, is also non-invasive, and it looks at the physiologic and anatomic properties of the heart. It uses a powerful magnetic field, so you do, just like with the MRI, have to consider any type of metal particles or devices that are implanted, and you need to remove everything that is metal on the patient as far as what is external. And this includes partial dentures. And then an echo, or echocardiogram, is also non-invasive, and it's done using an ultrasound, and it can test your ejection fraction. It can also look at the size of the heart. It can look at the shape of the heart, and you can watch the heart pump, and it can record that for the physician. You can have transthoracic. Transesophageal is not non-invasive. It actually would be invasive, but you can do both of those. So with the patient, as far as nursing goes, you want to make sure that they understand the procedure, what's going to happen, what is entailed in the test. You need to make sure they understand why it's being performed. They should not eat or drink anything for 6 hours prior to the study. Make sure that they have informed consent. Make sure they have a working IV, especially if you are doing the transesophageal one. Afterwards, you're going to make sure that the head of bed is elevated. You want to monitor their vital signs during and after the procedure, especially the O2 sat. They'll be on telemetry to make sure that nothing is aggravated as far as the heart is concerned. And then they're going to, after the surgery, be NPO until gag reflex comes back. So monitor their level of consciousness post-procedure, as well as their ability to swallow. Usually the patient will come around and be fully alert, and all of the medication and effects of the medication are reversed or gone within 2 hours. But still, you want to make sure that your patient is okay. And they might complain of having a sore throat, and that's just because they had to have very, very small scope that's in their throat. And then you can also do a cardiac cath. Well, you can't, but the physician can also order a cardiac catheterization, and you can actually work in the cath unit and just assist with cardiac caths all day if it's something that you're interested in. It is an invasive procedure. It's really neat to watch if you're in clinical and you're able to go down to their cardiac cath area and see one done. You actually can go in and the physician looks at the heart with a camera. It's used to assess coronary artery patency and to see if they need to have any type of procedures done, like cardiac bypass surgery. But it actually is really cool. They can also go in for a cardiac cath and see if they need to have a stent placed, if they need to put in any kind of balloon or filter to open up the different vessels of the heart. As far as nursing interventions, during the recover period, your client has to maintain bed rest with the head of bed elevated to 45 degrees. They have to be NPO 6 hours prior to the procedure. The client is going to be sedated, and this will make her or him more comfortable, but they should not be heavily sedated. So it just should be something that will relax them. They will have an IV just in case you have any complications. You do need to monitor the site post-procedure for any hematoma, any bleeding, any hemorrhaging. You want to do neurovascular checks, especially of the affected extremity, to make sure that there wasn't any kind of nerve damage done. Check their cap refills so that they still have good perfusion and there was no damage done to the artery and no clots were dislodged or formed that occludes the major arteries or veins that are going on in that affected limb. As far as hemodynamic monitoring goes, so there are different types of hemodynamic monitoring. If you have a patient who's in with an unstable cardiac condition, then you really need to be able to get in there and monitor the heart, see what's going on in a more direct way. So the best way to do that is through hemodynamic monitoring. And the different forms, there's central venous pressure monitoring, or CVP, pulmonary artery pressure monitoring, intra-arterial blood pressure monitoring can also be done. And you usually have a flush system that has normal saline. Sometimes it has heparin, sometimes it doesn't. You also have a flush device. You can have a manual flushing of the system and different stopcocks. You have a pressure bag that's placed around the flush solution, and it's maintained at 300 millimeters mercury so that you have a constant pressure. And the pressurized flush system will deliver 3 to 5 milliliters of solution every hour through the catheter, and that is just done to prevent clotting and also to prevent black flow of the blood into the system. This type of monitoring is done in the ICU, and the nurses who do monitor these patients will have specialized training specific to what needs to be done. Complications are uncommon, but they can occur. The different complications that you need to be aware of if you're going to monitor these types of devices, your patient can get a pneumothorax. There's a chance for infection, and that's because of where you're going. You don't want to have an infection in an arterial line that goes straight to the heart. You can also have an air embolism if you don't have the pressures the way they're supposed to be and air accidentally gets into the line. So as a nurse, you need to make sure that that doesn't happen, and then also make sure that you're monitoring for any early signs of any of those complications. So this is what I was talking about. Here's your pressure bag. My pen here. So here's your solution in a pressurized bag, and again, that's 300 millimeters mercury as far as the pressure is concerned. Here is your monitor so that you can see the readings. Okay. And then you have your flush stop lock device access here. And then here it goes right into the superior vena cava is where this one's at. Everything needs to be sterile, and it remains as a closed system.